Welcome back. I'd like to take a couple minutes and talk through other conditions that may be of important clinical focus. So I'm going to share my screen. There we go. So some other things that you might have to focus on as a clinician include suicidality. So there's suicidal behavior or non-suicidal self-injury. This is new in the DSM-5 TR. And you can have behaviors, suicidal behavior like current suicidal behavior or history of suicide attempts, non-suicidal self-injury, like cutting, burning, things like that, abuse and neglect. And this breaks down into like child maltreatment and neglect problems, adult maltreatment and neglect problems. You've got relational issues like with parents, siblings, spouse, intimate partner, problems related to the family environment, educational problems, occupational problems, housing problems, economic problems, problems related to the social environment, issues around interaction with the legal system, problems related to other psychosocial, personal, and environmental circumstances, like unwanted pregnancies, problems related to multi-parity, like multiple births, discord with social service providers, probation officers, and so forth, being the victim of a crime, victim of terrorism or torture, exposure to disaster, war, or other hostilities, problems related to access to medical or other health care, circumstances of personal history, other health service encounters for counseling and medical advice like genetic counseling, sex counseling, dietary counseling, things like that, additional conditions or problems that may be a focus of clinical attention, like wandering associated with a mental disorder, which is really common with schizophrenia, all forms of dementia, uncomplicated bereavement, phase of life problems like retirement, having children, marriage, things like that, religious or spiritual problems, adult antisocial behavior, child or adolescent antisocial behavior, and these are both where it's not due to a mental disorder, non-adherence to medical treatment, overweight or obesity, malingering, age-related cognitive decline, borderline intellectual functioning. So a couple things that I'd like to point out here. Suicidality. There has been a long-held belief that asking about suicide and talking about suicide increases the prevalence of suicide attempts. There is some evidence to support that. However, it is our ethical responsibility to check, to ask if they're having thoughts about harming themselves. I want to tell you a quick little story. I had a client who had schizophrenia and had been in and out of the criminal justice system. That's how I came to work with this person. And they had a chronic history of substance use, probably since they were, about 18, 19 years old. But they had a history of psychotic episodes and schizophrenia type symptoms from as early as 11 years old. And while they continued to be incarcerated, they would usually get incarcerated during a psychotic episode. They also had substances in their system. They were consistently diagnosed as it being substance-induced psychosis. At one point when I was meeting with the client after they had gained sobriety, they had been, supposedly free of psychotic symptoms the entire time they were incarcerated. The client disclosed to me that they were a very spiritual person and could call forth spirits to engage with them. That they would crawl through mirrors to interact with this person. And full blown, this is my life, this is my reality. When I pressed the the treating mental health provider at the jail and said, look, I'm really seeing symptoms more consistent with schizophrenia than I am with substance use disorder and substance use induced psychosis. They said, we will never give a diagnosis outside of that as long as every time we see this person while they're in a psychotic break, that they are under the influence of substances. And I said, I've got this medical record that goes all the way back to 11 years old. Substance use for individuals who have schizophrenia is not uncommon. You shouldn't just, ignore the potential for schizophrenia just because substances are being used. And they refused. My client had a strong history of wandering, which is common for individuals with severe cases of schizophrenia. They'll appear like just traveling vagrants. Just won't have a reason for why they go where they go. They'll travel all over the country, sometimes all over the world, depending on how many resources they have, without any real reason as to why they go where they go. And they'll just pack up and leave, at a moment's notice. So not a lot of consistency in staying and building relationships and so forth. This particular client, because they were constantly released, would get incarcerated because of their behavior when they had psychotic breaks. And I got this phone call from a friend of the client. They were currently at a hotel room, and the friend was afraid that they were going to accidentally kill themselves. And I said, what do you mean by that? And they said, well, the client believes that they can fly and continue to go try to get up to the top of the hotel so that they could jump off and prove that they could fly. And said that, right now I'm currently struggling with them because they are terrified because they believe that our room is filled with snakes. And I could hear my client screaming in the background. So in an attempt to distract the client, the friend says, hey, Dr. Poke is on the phone and she would like to speak with you. Do you have a minute that you could talk to her? So my client gets on the phone and is very distressed, very, very distressed and tired. And talking about making statements like, I just can't take this anymore. Things are never going to get better. Lots of hopelessness. I just think I'm done. So as a social worker, our profession actually calls us to be responsible for this and to ask, not waiting for it to be spoken, but to ask. And so I said, have you had any thoughts about hurting yourself or taking your life? And my client laughed and said, no, but that's a great idea, and then hung up. Because I worked in the criminal justice system, and specifically for the client's defending attorney, I was not allowed to make a report against their will. Not legally. I was not legally allowed to disclose it. So the best that I could do was to contact the crisis center, tell them that this person may be reaching out to please take it seriously and to provide services. And then to contact the friend of the client and say, you need to do everything that you can to try to get them into a crisis center. It was the longest 36 hours of my life. I honestly felt trapped, and that I had done the worst possible thing that I could have ever done. But the reality is, the client did receive services. The friend was able to get them into care. However, their psychotic episode was so intense, they wound up being incarcerated again and given the exact diagnosis again. And upon release, they immediately skipped town. You must ask. If you have any reason at all to believe this might be a risk, you must ask. Because if you don't ask, you won't know, possibly until it's too late. That's the first thing I want to say. The next thing that I want to talk about is how some of these problems have significant overlap. For example, housing problems. Individuals who are chronically homeless are definitely going to have comorbid issues, substance use issues or mental health issues, or both, can have chronic health, physical health issues. And you're going to be like, what do I address first? What do I do? One of the largest programs that's, well, not largest, one of the programs that's gaining a lot of momentum right now is the housing first approach, the idea of stabilizing housing and then providing the other services in order to ensure that they can stay stable in housing and improve their quality of life. The logic behind this is that while they're chronically homeless, they're in a dangerous environment 24/7. They are constantly fighting for basic survival resources. Where am I going to eat? What am I going to eat? Am I safe? Am I warm? Am I cold? Do I have a place to keep my things? If I'm sick, can I get help? Things like that, right? Physical safety. You will be required to start figuring out how to prioritize this based on the agency where you work, the resources that you have, and the resources that you're aware of within the community that you can connect individuals to. So I personally recommend that you start creating a resource handbook. I had one that was like this thick that I left to other workers when I left working at the public defender's office, because I was leaving the state. I was in Tennessee at the time. And so when I relocated to New York, there was no reason for me to continue to have that, because it was unique to the area. But what would be important is for you to be able to do that as well. So every time you find a new resource, you need to save that. You need to document it and put it somewhere where you can pull it back up and access it again. You'd be amazed at how often you will use it, even though it'll feel like it's intermittent use, not having to dig it up, look again, not having to try to find somebody who might know. It saves you and your client a lot of time, a lot of energy, and a lot of failure before true help is found. The next thing that I want to talk about is maltreatment, abuse, and neglect. As a child, for a client, we're all mandatory reporters. And I hope that you understand that. If it hasn't been discussed, it should be discussed at some point. Because a child cannot protect themselves and are completely dependent upon the adults around them. If we become aware of anything that suggests child neglect, psychological abuse, physical abuse, sexual abuse, we have to report that. And there should be a 1-800 number to Child Protective Services. It varies from state to state, but there should be a main number that you can reach out to make your report. And then they'll contact you, they'll ask more questions, and you provide the information that needs to be provided. In terms of client confidentiality, when there's threat to harm to the client and they are a minor, that confidentiality no longer exists, at least within the context of having to protect their physical being. In terms of adults, however, their confidentiality reigns. And unless they are an elderly person who is in a similar situation like a child where they cannot either physically defend themselves or physically escape the situation, then you have to report that too as elder abuse. Different hotline, but same kind of services. But if they fall in between, where they're an adult, but they're not elderly, they can generally escape on their own or can physically defend themselves, even though many of us would argue in some circumstances that's not the case. You are held to client confidentiality and you are not allowed to make those phone call reports. You're not allowed to share that information without client permission. And this can be difficult, especially if you're interested in working in domestic violence treatment. Most domestic violence victims will leave a total of 7 times before they leave for good if they are not murdered in the process of trying to leave. So just some of the caveats of working with those issues that you'll need to be mindful of and prepared for when you start to go into clinical practice. Problems related to interaction with the legal system. So I talked a little bit about that. So problems related to legal circumstances, charges and stuff like that. Another brief story. The legal system and the criminal justice system are very different animals to the rest of the world. It is a legal system, not a justice system. And so it focuses on rules and the very subjective nature of interpreting those rules for judges. But if you ever work with a client who is incarcerated, this varies across states, but a very common practice is called the chair. I was not allowed to disclose any of my clients' suicidality to the jails or prisons where I worked with them without going through their attorney first to make sure that it was absolutely necessary that it's reported. And that's because if the jail was notified that an inmate had expressed suicide ideation in any form, they would strap them to this chair. The arms would be strapped down, the head would be strapped back, and the legs would be strapped down with a hole in the seat where they would then be left for 36 hours. I was forced to go and personally see the seat and then spend just 1 hour at the jail and think about what that felt like. I wasn't even in the seat. Think about what that felt like and how that time duration felt to me. And then imagine what it would be like for that 36 times over, being strapped to a chair where you cannot move and you're forced to essentially just go to the bathroom where you are. You need to be mindful. So if you are going to work with clients within a criminal justice, criminal legal setting, you want to know what those governing bodies, those agency policies are around suicide ideality, delirium, other issues around mental health issues, non-suicidal self-injury, and so forth. You want to mitigate additional trauma and stress as much as possible. And sometimes the policy to remedy those risks is more damaging than trying to mitigate those risks on your own through whatever mental health support services you can provide. So it's a very delicate balance. So those are things that you want to be mindful of. Okay, so that was it. Other conditions that may be of focus for your clinical attention, some of the challenges that you likely will have to face that goes way beyond the typical, here's my diagnostic code. And all of these are not considered mental disorders. They are relevant and you can note them in your notes, in your diagnosis, to help other treatment providers gain a better breadth and depth of understanding of your client or patient. All right. Thank you for listening. And if you're interested, this is actually pulled from this. See if I can get it to zoom in for you. Okay, hold on. Stop share. See if it works. Okay, it's not gonna, because I have my background blurred, because you don't need to see mess that I'm currently living in. But it's the Quick Study Medical. It's called the DSM-5 TR Overview. It's a quick reference guide, and it's laminated, and it has all of the DSM categories broken down for like a quick at a glance. There you go. If you wanted to be able to kind of read them, it's just really helpful. It doesn't provide the same detail as the desk reference copy of the DSM or the full DSM. So to really be able to diagnose somebody and be mindful of the differential diagnoses, the potential consequences of having this disorder long-term, you need the full DSM, but the Quick Study reference guide helps you remember real quick at the top of, right off the cuff. You could be like, where is it? Okay, here it is. It's in this section. Let me look it up. Sorry, random hiccups. So again, DSM-5 TR quick reference guide. I think I paid maybe $20 for this or something. I got it on Amazon, so you can actually have it delivered in 24 to 48 hours if you're a Prime member. All right. If you have any questions, you know where to find me. Don't hesitate to reach out. And thank you for listening. I'll see you in the next lecture.